Welcome to the Pharmacist RN, a podcast made for pharmacists by pharmacists. Pull up a seat and let's get started.
Welcome back to another episode of the Pharmacists Are In podcast. My name is Ajit Johal. I'm a BC-based pharmacist, and I'm joined by my colleague, Dr. John Papastergiou. John, we are live from Pharmacy U, Toronto.
Live from Pharmacy U, we've got a very special guest, our first Shoppers Drug Mart associate. We haven't had one on today, and obviously near and dear to my heart. We've been in the system together for a long, long time. Mohamed Adel Elsabakhawi, and Mohamed's been a long time supporter of Pharmacy U as a delegate, as a speaker. He's been coming here as long as I could remember.
Correct. Yeah. Very.
What was your first Pharmacy U experience like?
I can't remember. That was like maybe 5-6 years ago. Very different, very unique. That it gives you practical tips that you can apply to the pharmacy practice the next day. Some other pharmacy conferences, you feel like it's all about theory, and you leave like, what was this? It was great, but what do I take back? Pharmacy is very different. You feel like you can actually apply what you learned the next day.
Yeah, and that's always been the goal of Pharmacy U. Practical, succinct kind of sessions that you know, and that's why I think the frontline pharmacists like to come, right?
They do.
Because it's, you know, if you think of historically CPHA, it was all academics. They're primarily, you know, pay, you get a mishmash, but members. Yeah, but here it's like frontline pharmacists generally, right, that are looking to change their practice or at least take home a few kind of novel things. And Mohamed's been kind of super active in the point of care space. He's me and him have worked in the area together for a long, long time. And I think your session was on point of care today.
It was.
Yeah.
It was packed. It was great to see many people there.
Yeah, it's something we've, it'd be interesting to get your insight. I feel like we had this movement forward in point of care, you know, and then we were hoping for scope or more scope to come as maybe some reimbursement, but we've almost kind of hit like a little bit of a standstill here in Ontario and in some other parts of the province, you know?
I agree. I think it's long overdue, and this is the tip of the iceberg when it comes to point-of-care testing. It's really needed, and it's making a big difference and a good impact on patients' health.
Yeah, well, we know that, and we've done work together even. We presented at FIP together. We've posters. I think when point of care took off, Mohamed, even more so than I, really was able to operationalize it, put it into practice, you know, get his staff to do it, to buy into it. That's always the hardest part, right? How do you change? But, you know, it's we're still waiting on strep scope here in Ontario, you know, like it's unfortunate because we've done all the groundwork, and now we just want to see the regulatory change and the reimbursement hopefully come, but I think it's going to come still. I mean, just when?
I think it's going to come, absolutely, because there is a big need for it, and more people, they need access to care. And to your point, I always say, John, you're the father when it comes to the point of care testing. It's really needed, and it's making a big impact again.
And I think Mohamed's, I don't know if you've had a chance to hear any of his talks, Ajit, but he really takes like experiences from his practice, and I think that's what pharmacists need to hear. Well, like, these are my patients.
Yes. So I really liked your talk this morning.
Thank you.
I was able to attend between the shackles of the podcast. And what I liked is you kind of use motivational interviewing. You use a lot of those, like Simon Sinek, Stephen A. Covey. So it's a very practice change mentality. And you even quoted Jeff Bezos as well. What was it? Stubborn and flexible.
Exactly, and you need to know when to be which.
Yes.
I feel like a lot of this is actually motivating your staff actually to convince them to see it as an enabler. Point-of-care testing, not as a burden, because it's so easy to just sit on the shelf, John. We know some pharmacies that it's just collecting dust, right? So to your point, Ajit, yes, I used a lot of this, and I was like, how do I convince my staff? And it's all about the why, and then I go from there, how can I convince them? And it's the sky's the limit, and the staff, they really like it. And the good thing about point of care testing as well, it's also helping me with recruitment and retention.
Yes.
I'm getting a lot of actually pharmacists knocking on the door saying, you know what, Mohamed, I would love to work in your pharmacies. I want to be part of something special. And to your point, John, when we go to FIP, and a lot of pharmacists from different areas of the world, they're saying, oh my God, you guys are doing this? This is really cool.
It is a differentiator. I always tell Abbott, I joke around with Abbott because we use the Abbott devices in our stores, is without the pharmacists, these are expensive paperweights. You know what I mean? Like, they're nice, they're there, but it's really the pharmacist now that's taking the data and interpreting it and getting the buy-in from the patient and engaging them and getting them to kind of take a different look at whatever disease state you're examining, right? But it's such a powerful tool. We're talking about 10 microliters of blood. It's nothing, to do it. I mean, this has changed. When I started, it was a lot of blood you had to do. Now it's literally nothing, a finger prick, and you could get all this valuable information. But there's something, Mohamed, that's still a barrier to a lot of practice sites. Still not buying it, even though they have the machines. They've got the machines. They've been trained. They're still struggling to implement it into practice.
It's the leadership. Once you have the leader of the pharmacy really believing into this, that's why I talked about consistency near the end of my presentation. When you have the leader believing into this and seeing it as an enabler, it's a game changer. I would love to have somebody from the government, and then we can go through some of the data that we have. This is going to save the government. Just to throw a figure right now here, $45 million in the next 10 years in complications. The way that we did this, and you don't test everyone. We're not going to screen every single person that comes into the pharmacy. There are specific risk factors, and then when you catch them, you're making a big impact.
I would say 45 million is a very conservative estimate, because when you look at, I saw an article in the Toronto Star, because John, there's all this conversations around Ontario. I know it's the center of the universe, but it's what is the growing epidemic in Ontario? It's chronic kidney disease, and it's coming earlier, it's coming fast, it's coming aggressive. And what causes chronic kidney disease? Well, it's uncontrolled hypertension, uncontrolled diabetes. A lot of those point of care tests can catch those things early and slow that decline. You can prescribe medications to slow that decline.
We published a paper on that probably 10 years ago now.
You did,
That's exactly what we looked at. We looked at high-risk patients, smokers, diabetics, hypertension, obese, common risk factors, never been tested. Big sample size, about 700 patients. And it was about 13% of them presented with stage 2 or stage 3 dysfunction.
And they had no idea.
No idea. And this simple test, back then we were using the Piccolo device, so you need a little bit more blood, but still, now technology's gone better, man. You don't need as much.
What's funny is I had we were doing point of care tests for employers, and we were using the cardio check.
Oh yeah, cardio check.
It's just like an old school T183 calculator, right?
Light photometry.
But it's quite a bit of blood for the lipids. So the student was like, "This isn't a finger prick; it's a finger slice."
Now,
so it's like,
now it's so much easier. Like you could do an A1C; it's nothing, man. The A1C.
And it's a game changer, because our customers, they say, "No, I don't like needles." I'm like, we're not taking blood from. It's not vein. It's a finger prick. How long do I have to wait? Less than 10 minutes. Do I need to pay? No, you don't have to pay. Do I need to fast? No, you don't need to fast. How accurate is it? It's lab accurate results. So it's been a game changer for us.
So my worry is, and I like to talk about pharmacists because I spent a lot of my career in pharmacogenomics, now point of care. If we don't move fast enough, someone's going to take over this space, right? And I see it coming. I was just in at A4M, big longevity. They've got tech now. It's called the Tasso. It's a little device. They ship it to your house, you put it on your shoulder, and it's like it draws enough venous blood. You don't even feel it over about 40 minutes, enough blood, throw it back in the mail, and you get a comprehensive analysis. Not just lipid panel and A1C, like everything. C-reactive protein like wild. And this is going to come. And if pharmacists don't move quickly, someone else will take this tech and just operationalize it, and we'll be cut out of the whole loop,
For sure, but I think you still need a clinician in the loop, right?
Well, no, they have clinicians. It's not the freaking pharmacist, right?
I see. So they got some on the back
end.
Yeah,
of course. They're going to have them. They're going to have them at the company or wherever it is, or someone's going to start offering it. But the reality is we're here, we're talking to the patient, like Mohamed's talking to them every day.
So how do we not let this happen?
Gotta move, man.
So what does movement mean?
I don't know. Me and Mohamed have been trying to move this space for 10
No,
years,
I think
man.
no, I think Mohammed's been a true leader in this space,
yeah.
and he's moving at a great pace.
It's not the Mohammeds or me. We gotta get the people with the devices in their stores already to start using them. I think that's the most important part.
I agree, absolutely. We need more people to use it. But back to your point, if we don't move fast enough, this could happen. But I feel like the customers, they really want that one-to-one relationship with a healthcare professional.
Mm-hmm.
So I was talking about, in the session today that Amazon, everybody's worried when Amazon comes to Canada, they're going to disrupt the pharmacy landscape. But they can't really compete with the pharmacist-patient relationship. And point-of-care testing is a true enabler to strengthen that relationship. So you have meaningful discussions, and through this, and we're learning about, depression diagnosis that nobody knew about, and then we refer it back to the doctor. And that's a good, segue to this, that it's the narrative that we need to be working with the doctors here and other healthcare professionals. We're not there, it's not turf war, we need to work together. And there will be never an empty seat at the doctor's office as a result of expanding the scope of practice for pharmacy. So we're there to increase access to care.
Definitely.
And we've got Mohamed here now, so we might as well ask him. You're one of the pioneers in our network with the in Ontario, anyways, with the pharmacist-directed clinics as well. You have 2 stores now that have it? Three that have
3.
So pharmacist-directed clinics. So Mohamed's probably got more experience than anyone now in Ontario.
I would say in the world.
Yeah, how's that going? How's it going?
It's great. I think it's a great concept, but more importantly, it's all about the staff. Because we have the exact same scope of practice like any other pharmacy.
Yes.
So it's nice to have the clinic, and it increases capacity. It allows me to hire more pharmacists. But at the end of the day, you need to train your staff to see patients with a lens of a clinical lens. When they come in, they need to. The doctors, that prescriptions for vaccinations are decreasing. They're on the decrease when it comes from family doctors. They don't have time. Who's gonna promote this? I think the pharmacists are playing an integral role, and Ajit, you're a leader when it comes to this space. The pharmacists, we play a huge role in increasing vaccination rates. So because I have the 3 clinic rooms, that allows me during flu shot season that it's not just during the flu shots. We're talking about vaccinations throughout the year. We're talking about point-of-care testing throughout the year. Travel consultations throughout the year. So, and point-of-care. So back to your point, John, it's been a game changer. It's great, and it elevates the experience. The patients, they say, you know what? I feel like I'm checking in a to go in a spa.
Yes.
Or a nice area. It's and it allows me again with a retention and hiring, as I said.
So, for the audience that may not know what we're talking about, just explain a little bit about kind of, because not every pharmacist will have seen one, or even, I think we're used to it in our network, but describe how this looks, because your pharmacies are spectacular, the layout and everything else. So what would a patient experience right now if they came to your pharmacist-directed clinic?
So I'll start during the pandemic. A lot of people were just coming and they didn't know where to go. Are they here to fill a prescription, to get a vaccine, to get a COVID test done? So what we did, now we have a care concierge desk. It's like a receptionist in a doctor's office, but a pharmacy assistant that can help patients navigate through what they need. So if they're here to fill a prescription or to get a flu shot or to here for a point-of-care testing, and then according to the needs, she would direct them, or he or she would direct them either to go to the dispensary to get this done or to go into the clinic rooms to get one of the professional services done in the rooms. It's quite unique. We have a kids-friendly clinic, like a room where it's kids friendly. So it's basically 3 consultation rooms that we call it clinic rooms with a care concierge, a new concept that we created at Shoppers Drug Mart.
And is it all appointment based, or can someone walk in and talk to the concierge?
Mix of both. A mix of both. And I would say, like today, I actually shared on the slides that 75% of the services that we've done, it's actually walk-in basis.
Okay.
25% is appointment based. We aspire that one day the clinical pharmacist would start the shift and everything is booked. We're working towards this. We're at 25% now. And this is the tough part, because it's the chicken or the egg. Do you book the pharmacist first and then wait for the patients, or do you book the patients first and then wait to get the pharmacist? My point is, start small. invest an hour or two of someone to make calls, and then once you have those calls and appointments booked, get the pharmacist early for 2 hours.
And what are they coming in for most often, Mike?
Point-of-care testing is the bread and butter of everything that we do. But it's now, if you speak with my clinical pharmacists, they're like, you know what? It's never a dull moment. It's either they're doing COVID, they're doing vaccines, they're doing travel vaccinations, they're doing point-of-care testing appointments.
Vaccines, yeah.
Vaccines. We have a medical directive actually now to give vaccines. So this is really helping us.
So, do you ever get patients coming in that think it's like a doctor's office, like I broke my arm and stuff? Yeah, I think.
They're like, is there a doctor there? And the good thing about this is it shows that there is appetite, trusting the pharmacist. Oh. So, minor ailments, not everybody knows about it, but those that know about it, they come to the pharmacy and say, you know what, I hear now that the pharmacists, they can assess and prescribe. Can you renew my metformin prescription? I'm like, wow, not yet. We would love to come to that point, but that shows that there is a level of trust and they want to come to us for these things.
But you see, like we had before, we were talking with, can't remember which group, around chronic disease prescribing, but imagine if we had the scope right now, like Mohamed had that scope in his pharmacy. I mean, he could be managing the entire spectrum of chronic disease. I mean, we have they have the facilities now, the ability to do it. I mean, access to labs. It's a no-brainer. I think that's where we got to go next.
Well, I think the big thing, and I've talked to Mohamed about this, is with every point of care test, there's a potential for it to be out of range, and there needs to be an intervention, right? So vaccination is an intervention. If someone's A1C is high, there potentially needs to be a change in pharmacotherapy, and you should be able to do that. And that is, I think, is what's missing.
Yeah.
And even renewing the metformin, I mean, maybe it's not appropriate to renew as is. Maybe you need to increase the dose. Maybe you need to add something. But
Ajit, we did 6,000 point-of-care testing in the last 14 months. And guess the percentage of the patients out of range?
20%.
62% of patients that they came, one of four things was out of range for them. So either their Framingham risk score was out of range, their LDL was out of range, their blood pressure was out of range, or their A1C was out of range. So it shows that there is a lot of gaps in care out there in the community. And then you have pharmacists who are very accessible and trustworthy. Patients do trust the pharmacist.
Those are all things they can manage, right?
Totally.
Everything on that list could be managed by the pharmacist, right? Yeah, it's so short-sighted. I think but like I said, we got to move. We own that relationship, but it feels like we're spinning our wheels a little bit, I get it when we started down the path of pharmacogenomics. It's expensive, you need a little bit more specialized training. Not all the patients understand, but you get into point of care, it's actually a lot simpler, right?
It's very black and white, right?
Correct.
It's very black and white. So, but I always tell Mohamed, if you're, eventually the scope will change and you'll be ready.
Yeah.
For implementation.
We're ready to hit the ground running.
Exactly.
Yeah. So hopefully we get there soon. I mean, sooner than later. We're going to have OPA on. We're going to grill them a little bit.
I think so. Yeah.
About what's going on. It'll be good. But no, Mohamed, thanks for stopping by. I always thought Marty should have a list of frontline practicing pharmacists that could, be at these events and do these side sessions, right, where they talk about kind of what they've done in their practice and how it's impacted their patients. And I think that's a great way to get buy-in. But Mohamed's living it, right?
Well, he is. Well, I think even a point-of-care masterclass.
Exactly. I was just going to say that.
Yeah.
So it's in the works. We're just finalizing some details. And it's one thing to talk about for point-of-care testing in an hour, but it's a different thing to actually to train people and to touch it. It's to make mistakes and to learn how to do it.
What are some real examples of things that could happen, right?
That's what I love about your presentations, Mom, is you talk about the failures of execution. That's where you learn.
It's part of the success.
So that's how you learn from people, is you learn from what didn't work and what works for them, and you have such a great insight.
Yeah,
100%. That's the only way it works. By making as many mistakes as you can.
That's it. Yeah.
Awesome. Thanks, Mohamed, for coming in and sharing your story. I know we're getting late into the day now, but it's always interesting to hear from what's going on the front lines, and I'm sure we'll see Mohamed in Vancouver probably.
Yes, definitely.
Thanks, Jonathan. Thanks, Ajit, for having me. Always a pleasure. Thanks.
Thanks.
Thank
awesome.
you. Cheers.
Down.